It's great to be here, and this is really exciting to have this visual get created as we're doing this. I was thinking this would be a nice thing to export back home as a capability. It's a privilege to be here with these distinguished leaders coming from different sectors of the healthcare space, and hope to have a really engaging conversation that will, I think, similar to the prior panels, just kind of set the stage for questions and further conversation about how can we advance the ball down the field in terms of better control of the risk factors of heart disease and stroke. Because there's a lot of great work that's going on and a lot of opportunity for improvement. As John opened up this morning, he reminded me of a British philosopher, Bertrand Russell, who has many great quotes, but one of the quotes that I'm most sort of enamored of is the three passions, simple but overwhelmingly strong, have governed his life: the longing for love, the search for knowledge, and unbearable pity for the suffering of mankind. The last one's a little harsh. But I think that those actually capture the theme of the forum, the theme of today, in terms of, if you think about love in the context of relationships and the ability to connect with others, you think about the quest for knowledge that we're all after. And then you turn that last piece around in terms of the pity for the suffering, but you talk about what John said is the privilege and maybe even the responsibility to help alleviate the suffering that we see from the conditions that we're focused on through the forum, heart disease and stroke. And I think it represents a real opportunity. And I think that's what the panel is really here to help share about. So the bios were in the folder, all distinguished careers here. And I want to give Chris a little leeway here because, well, he's been at the CDC for quite some time. He's only 6 weeks into his role at the head of the 618 program, so we'll cut him some slack along the way. But I guess what I'd like to do is to start with you, Chris, and give us a little context in terms of what you're learning as you go forward with the 618 program.
Sure. Thanks, Mike. Is this on? Okay, there it is. Yeah, so thank you guys for having me. It's a pleasure to be here and a part of this panel. I think that I'm suspecting most folks have heard about 618, but I'll provide a summary of it, or I see some heads shaking, so I will definitely give a summary of it. I'm just started a rotation in the Population Health and Healthcare Office at the Office of the Director. It's in our policy office. And our office is focused on expanding collaborations across healthcare delivery and public health to try to advance population health. And the 618 initiative sits within that office. The initiative is really aimed at amplifying all the great work that's happening around the agency and the divisions and offices and the strategies that they're promoting. And so we provide implementation support for those evidence-based interventions that the different topic areas are promoting and that they've researched and have shown to have health impact and cost benefit. So we work collaboratively with our CDC offices, with CMS, with the Center for Healthcare Strategies, with ASTO, NACDD, the National Alliance of Medicaid Directors. I might get some of these wrong, but I'll do my best. And then also, and through that, we work to promote so that there's 6 topic areas that are high burden, and then the respective strategies underneath those, the evidence-based interventions. I'm happy to talk more about how we got there, but I will spare you guys of that unless you really want to know. But we've been promoting this work for now 3 years. We're going into years 4 and 5, and the initiative is funded through the Robert Wood Johnson Foundation to CHCS to provide that coordination support and technical assistance. And CHCS has done a really nice job of setting up the operations, the structure, the learning collaboratives, a lot of peer-to-peer learning, and then helping that engagement across the state health departments to the healthcare delivery system to the state Medicaid offices, et cetera. And that's really where we focused the first couple of years. We have 34 states working with their Medicaid offices around the different topics and initiatives. And then today I'll talk a little bit about the initiatives specifically related to heart disease and stroke prevention with tobacco, smoking cessation, blood pressure control, and then diabetes. And I'll stop there for now.
Thanks, Chris. One of the hallmarks of the 618 program is the 3 key phases, looking at Medicaid coverage, provider adoption, and consumer utilization. And I think the panel is perfect in terms of covering those dimensions. So, Tim, let me turn to you in terms of provider adoption, your in-depth experience in working with providers, and what are you seeing in terms of some of the successes in terms of provider adoption with some of these best practices that are out there?
Well, thanks for the invitation, John, and others for allowing me to participate in this. But I've only been in the job at the ACC for 14 months, so a little longer than Chris in his job, but I'm still a toddler at the ACC, and I know there's some fellows of the American College of Cardiology in the room, so thank you for your support. One of the things I would just mention at the outset is I think we're at a very strategic inflection point when it comes to adoption of some of these evidence-based approaches, primary, secondary prevention. And I'm going to get on a soapbox just for a few minutes, so pardon me as I do that. But I think the problem that we have encountered is that we don't have a lack of knowledge. Maybe there is a knowledge gap to some extent. I don't think there's even a lack of desire that exists within the provider community, hospitals, physicians. I think what we have is very poorly aligned incentives. And I read an article recently posted by Jeff Morgan at Deloitte. It's a blog, actually, but had a catchy title, Star Trek Medicine in the Era of Flintstone Reimbursement. So I thought that said it all right there. So there are 2 elements of compensation or reimbursement or financial incentives I'd like to touch on that I think affect our ability to implement. And I think it's an implementation issue, not a knowledge problem and not a will or desire problem. I actually don't think we even have a lack of resources. We have plenty of resources in the U.S. to address these issues. But the first one is how hospitals and physicians get paid by payers. I think that does not align itself well with this type of population health management. Matter of fact, I would submit, to get back to my soapbox, I think we're at a point where we need another DRG moment in the U.S. I shared this with John when I met with John a few weeks ago. When DRGs hit, and I'm old enough to remember when DRGs hit, in 1982 they were adopted, they were phased in from 83 to 86, and I remember at the time articles in the newspapers around the country saying so many hospitals will close, hospitals are not going to be able to survive the impact of DRGs, and hospitals survived so well that Senator Packard, who was a Republican from Oregon at that time, he was the Finance Committee chair, he held a special hearing in 1986 with hospital leadership saying, how did you all get this so wrong? You said hundreds of hospitals will close, that will never be able to survive the implementation of DRGs, but here it is, 1986, and hospital profits are actually better now than they were before. And the answer is financial incentives work. The incentive before DRGs hit was to drive up costs and to not have good throughput. So what did you see? Hospitals were large. As I'd like to joke, some of the dumbest business people ran hospitals because it wasn't that difficult to run a hospital at that time. All you had to do is just have your costs go up. You don't have to worry about throughput. So we're at a point where we need another DRG moment. I would call it a mega DRG moment that we need, something that really creates a team-based incentive and co-management incentive between cardiologists, family medicine docs, internal medicine across the board. We need to have a team-based approach to solve these problems. The second thing, and I promise I'll get off this soapbox in just one more minute, I think the way we pay physicians inside of the enterprises that employ physicians is also in need of major overhaul. Paying physicians on a per worker RVU basis turns every physician into a widget maker. They don't think about value anymore. They get dumbed down. The suits like me try to tell them how to see patients faster and work through and just move those clicks or save all the documentation to the end of the day. So value, true value creation, is not embedded in a worker RVU. If you tell people you're paid on a production basis, guess what? Some of them will produce. They may not produce so well. They may not produce with good outcomes. They may not produce with happy patients. So I think the adoption of some of these very clearly proven evidence-based approaches are only going to be it's only going to be at a high level when we fix both the macro incentives, how hospitals and physicians are paid, and then within those systems, how physicians are paid to do quality work, not just produce work. I'm off my soapbox now.
Well, thanks, Tim. I think you hit upon a couple of key themes here: alignment and incentives, and we'll come back to those because I think those are really important, as was brought up in earlier panels as well. But Mike, you're a little bit closer to the consumers in terms of the commercial side of things, and we know that getting some of the results that we want to achieve, part of it's on the providers, and part of it is on the consumers, and where they spend their time, and they spend a lot of their time at work. And you represent some significant national employers with your association. So, what are your thoughts to open this up?
Sure. So, just to put some context, we represent the employer coalitions across the country, the regional employer coalitions across the country. So it includes the private sector, Fortune 100 companies, 60% of the Fortune 100, a lot of mid-size, generally self-insured. Also includes public sector employers, states, cities, federal government, school districts, also union groups, UAW Trust, 32BJ, things like that. So collectively, it's about 45 million Americans. This is an interesting topic. You would think that nobody was watching the store, and we weren't all that concerned about health. And of course, corporate America has been investing in wellness for seems like ever. I mean, for 30 years, and what do we have to show for it, right? So it's a little bit of a scary thought when 85% of employers have a wellness program, and we're getting less healthy. So that is so I think our challenge, and I think our opportunity, is to think about what has worked, because there are pockets of what has worked. And how do we accelerate those things that have worked? And this is the idea of being more evidence-based and moving that. There is certainly a strong movement towards moving towards a culture of health, making this how we do things, embedding it into how we live our lives at work and at home. But again, we got a lot of work to do. I think we have activities relooking at the whole issue around obesity, with learning from kind of the science of obesity and how that is emerging. But frankly, the gap between how people are operating and what the current thinking is wide. And so I think we have a change effort that is major. I also will just offer that from my perspective, when you talk about payment reform or you talk about providers or payers and all that, I really think that the employers do more than just influence their employees. They influence their suppliers too. And so if we get on the same page, we can move the whole system, and I think that's the opportunity.
Great. Mike, why don't we stick with you for a little bit, because you and I had a chance to talk a little bit about what Tim was referring to in terms of incentives around payment. And I don't want to get on my own soapbox, but we've got a new payment model that we've been in with our primary care docs for about 8 years. It's really rewarding them for achieving the right results. But you've also got some experience with employers stepping out in terms of advancing better payment models, and I wonder if you'd be able to share some of that with us.
Yeah, there have been employers that have stepped out in direct contracting type initiatives, and oftentimes they're really starting with hospital-based type contracts. I think more recently we are stepping back and looking at what are the opportunities going forward, and I think it very much aligns with our conversation earlier and your conversation just now, which is the first is advanced primary care. I think the reality is there are great examples of leading practices in primary care that are getting amazing results in improving the health of populations today. And I won't name all the names, but I think we all have some names in mind. But we don't pay them that way. They've actually recreated how they get paid. And if you do recreate how they get paid, we're not an advocate for, just pay more for primary care. It'll take care of itself. that isn't accountable either, right? So what we're trying to do is better define what advanced primary care looks like. What is the advanced primary care that delivers those results and truly adds value to not just the patient, but to the purchasers themselves. And that includes the downstream referrals that happen out of that and the amount of referrals that happen out of that. A lot of that is a more accountable system, and we're in the process of actually doing a report on that as we speak. The second area that we're focusing on is episodes of care. And you talk about team-based care and accountability for the patient end-to-end with warranties and all of that. We think that matters, and we need the incentives to be more line of sight. I think kind of capitating a system is simply shifting risk to a system. If underneath that people don't have line of sight incentives, that doesn't necessarily affect the changes we're seeking to make. So we are focusing on slowly, and it takes a long time to move it, but slowly moving that. And interestingly, I'll just share this one anecdote and then I'll stop. Interestingly, it's the public sector employers that are moving fastest in this regard. And a lot of this has to do with they can't afford to let this thing keep getting out of hand. They don't have the ability to shift. One, they have geographic concentration. Two, they don't have the ability to shift the cost to their employees as much as the private sector has. And three, they don't have a place to pay for it. So if the costs go up faster than taxes, they have to cut down on school teachers or firefighters, and nobody wants to hear that. So the public sector is turning out to be a leader even within our community.
And I think it was last year that we heard from Jim Schmidt, the mayor of Green Bay. And, Jim and his work has been carried on by his successor, where they have really invested in some of these, I would call, a little bit easier to implement, meeting the patients where they are, best practices to engage people in healthy habits. And the results that they've seen are significant in terms of reduction in overall expense, improvement in overall health status, and a more healthy, engaged workforce in Green Bay. So it's a great public sector example, stepping out and leading the change. Tim, can we talk a little bit about physicians' roles, but also physicians' roles in engaging and accepting other players in the ecosystem? Because we heard earlier about some of the great work that nurses are doing, and there's abundant literature to suggest that actually nurse-run hypertension clinics do a far better job of achieving results than physicians do. So wondering, how the cardiologists and physicians you represent are reaching out and engaging others in this ecosystem.
Yes, a couple of interesting things there. There's a growing shortage of cardiologists in the U.S. I think if you look at Dr. Sidney's slides before, and you look at the demand that's occurring, and you look at the number of cardiologists serving that demand, we are having an increasing shortage. Now, one way we're dealing with that, and by the way, 80% of cardiologists in the U.S. work for a health system. When I started in cardiology from the business side back in 1989, that number was very, very low. Other than academic cardiology, everybody else was private practice. In the last 10, 12 years, we've had a big change where cardiologists have become employees of large health systems. And of course, we know large health systems are getting bigger. They're more consolidated, more market power where they are. So one of the ways that cardiologists are dealing with this is there's been a widespread acceptance in the cardiology community of advanced practice providers, nurse practitioners, and PAs. I have personal experience with this, proving what you just said, that as we started a heart failure program in Northeast Tennessee, we called it Heart Success, by the way, instead of heart failure. That was the name of our program. So we started that program, but it was run by a nurse practitioner, several nurse practitioners that we had invested in to develop their skill sets. We had a medical director who oversaw the entire operation. But the nurse practitioners did a far better job of educating patients, engaging families, dealing with prevention issues, et cetera. And the patient engagement and patient activation, which is two separate things you can measure, the patient activation was sky high by comparison to the physicians. So I think there's widespread acceptance in the cardiology community, maybe tension 10, 15 years ago about what effect this will have in terms of on compensation or income. but everybody has realized the demand is so high, you need to create good capacity to manage that. And patients with chronic problems, heart failure, AFib patients, et cetera, these are patients that are perfect for a disease management program that is run by advanced practice providers and a team-based care approach. I've seen that work, and we actually have several models. The ACC and some other organizations have developed standardized models and toolkits to help cardiology adopt this. So there's two benefits that the cardiology group or the health system derive very quickly. Number one, they increase capacity. So those patients may have been seeing an MDDO cardiologist. Now they can see someone else. The MDDO cardiologist can work at the top of their license seeing other patients that may not have been seen. The second benefit is you have better outcomes. The time with the patient, the standardization, the following an algorithm, that's one of the things you can establish as a nurse practitioner and PA will follow that algorithm, maybe sometimes more rigorously than a cardiologist might follow that algorithm. We have good data to back that up. So I think the disease management and the population health management, it is a team sport. And I think most cardiologists today realize that they're part of a greater team. Even cardiology itself has become sub-specialized with interventional cardiology, heart failure cardiology, imaging, electrophysiology, et cetera. It takes a pretty big cardiology group now to take care of a group of patients, 10, 15, 20 cardiologists plus advanced practice providers. And some of the groups that we represent inside the ACC, they have a 1-to-1 ratio of physicians and APPs. And that's not out of the question. If I would have said that 10 years ago, cardiologists would have said, what, have you lost your mind? 1-to-1 ratio, what's going to happen to us? Well, now we've adopted that, and actually everybody is busy, and the quality is better, and the financial performance is better.
Great. I love that saying that population health management is a team sport. And I think that I'd like to come back to you, Chris, in terms of the leadership role that CDC is playing with these 6 high-burden, high-cost areas. Now, not all of them relate to the National Forum's agenda, but clearly tobacco cessation, the hypertension, which on the CDC website, talking about 618, isn't exclusive to hypertension. It's also giving deference to lipid management as well, and then diabetes. And I wonder if you could share with us what you see as some of the best practices in terms of creating partnerships and some of the successes you've seen in some of those areas.
Sure. So I think we've done a first round of interviews and talking with partners at the states, and there's a couple journal articles that are out now about that. But we have just recently finished a larger, we interviewed 10 states and several people across those states, and we came back to partnerships in the end as like one of the biggest drivers for the initiative and where we've seen those successes. And so I think that it seems like that getting these partnerships across the healthcare system to public health and getting the payers involved has been a really important driver. And so having folks within our organization that are embedded with CMS and working closely with CMS, and having CHCS working closely with CMS and helping facilitate those relationships at the state level, and working with the health departments to make sure that they're engaging with the partners that need to be at the table around the services and the health systems to be provided, or providing the services. And then also with our partner organizations in ASTO and NACDD, and providing that expertise from the perspective of the state health officers and the chronic disease directors. I think there's a couple really good examples. We were talking before the session about Rhode Island as one example, and they were able to work, and I'm pulling on an asthma example here, but that one of the big successes they had early on was being able to pull together 2 of their MCOs and get some of the processes changed to allow better access to the asthma program and implement those changes within the state. And then that's been one, that's one example of it. And I think, Mike, you were talking about being in Rhode Island and seeing all those partners together at the table. And it is really unique. And I think that CDC's role has been to help coordinate and facilitate that and provide the evidence. And then we've let the states drive the pulling the right partners together and figuring out how to work with CMS, and CMS providing that guidance. So I think, Million Hearts is another good example of an initiative that is deeply connected to CMS and having that success of those organizations working together instead of siloed.
Yeah, as you mentioned, Chris, I had a chance to be in Rhode Island and speak at a meeting last week, and watching the representatives from the Department of Health, Department of Health and Human Services, the Office of the Health Insurance Commissioner, Brown, and a lot of NGOs kind of be on the same page and get that kind of alignment was pretty powerful. And hats off to you guys for being a part of facilitating that success. The three buckets that the 618 initiative is working in, the traditional clinical interventions, those that extend care outside of the clinical setting, and then the total population or community-wide health initiatives, I think really set the stage for looking beyond the clinical evidence in terms of the implementation evidence. And I wonder if you can talk to how CDC is taking a look at determining those best practices and beginning to share those best practices going forward.
Yes, so there's another initiative that sits within the office. It's called High Five. It's addressing high burden issues that can be addressed within 5 years, and it is really looking at that third bucket around community prevention. And so we have followed a very similar process to identifying the evidence and the strategies that rise to the top and the conditions that are highest burden. And so the two areas that we're focusing on right now through that initiative are public transportation and then earned income tax credit in trying to address issues around poverty. So right now we're partnering with the CDC Foundation to work on developing evidence briefs and evidence summaries around that. And we should have some resources coming out later this year, early next year. And we've started with the earned income tax credit as one of the areas that we're focusing on and trying to pull together resources on how states can work to implement that and how to partner with other partners. And then we're trying to work backwards and how that then connects to the high burden issues under 618 and aligning with our agency winnable battles as well. So we're working with our birth defects office on some of that work around earned income tax credit and some of the other offices as well. So it really is a nice opportunity to look across those three buckets and that continuum and find ways that we can work within clinical care and then find innovative ways to advance that work and then look to expanding that into the community level and finding ways that can help, with public transportation, the ways that can help get people to their appointments and get people access to services and keeping those doors open.
So Mike and Tim, wonder if you could share some of what your experiences have been in terms of successes around the implementation of best practices, either in the employer world or in the provider physician space.
Well, I've got one example that I thought the audience might find interesting, and that's community paramedicine. So when I was the CEO of a hospital in Northeast Tennessee, one of the things that we encountered is 50% of our patients came from rural areas. So we had 50% more or less urban, suburban, but 50% out in the hinterlands of hillbilly land in Northeast Tennessee and Southwest Virginia. And one of the things we learned is the people who know some of those frequent flyer patients the best are the local paramedics, volunteer or paid in those communities. So we developed a pilot program where we sat down with the paramedics. Some of those were county agencies. Some of those are just kind of what I call the ma and pa EMS volunteers out in the middle of hills and hollers of Southwest Virginia. But that program worked very, very well. Matter of fact, I was surprised. If you go into a little town in Southwest Virginia and you ask, who are the 4 or 5 patients that you think are most likely to be admitted to a hospital today, the community paramedics, they know. Those are people they go to church with. They see them every day. They know their social situation. They know their living conditions. They know what they're up against from a housing standpoint. So we developed this collaborative program, and it was very successful. And I think some states are now licensing community paramedics in a different license category from your typical EMS paramedic to be able to do home visits at a very low cost. So we were doing home visits through this program at 1/3 to 1/4 the cost of home health nurses. These were patients that wouldn't otherwise qualify for home health. The physician could order it, but they wouldn't qualify. So we were using community paramedics to be another touch point with those patients. Some of those were done post-discharge. So the first 7 days after they were discharged from the hospital for another admission for heart failure, if they went back to that home, we actually had the community paramedic go out to the home at the time of discharge, going with the patient and making sure everything is set up in the home so that they would be less likely to come back for a readmission, and then have another visit with that community paramedic maybe 3 or 4 days later to make sure they go get their prescription filled, go to their doctor's appointment, etc. So looking for these innovative solutions to use low-cost existing resources in the community, that all you need to do is better communicate and connect them together with both post-discharge communication and then routine interaction with those patients at risk.
And I'll build a little bit on that, but maybe with a different slant. For years, employers deployed a lot of wellness programs, a lot of disease management programs, and each was designed to target something in front of them, right? This, that, and the other thing. And not a lot of results to show for that either, right? And I think, but there have been some bright spots, some very significant impact on improving the health of the population and engaging individuals on their own personal health more effective. And the common denominator that seems to be there is looking beyond the issue in front of you, looking at the individual as a whole person, right? Which is a lot where you're going with that. That includes not just their eating habits, but their social situation, their mental health. All those elements turn out to be very interrelated, and you can't just talk about the thing that's in front of you, or even that first level of causation, without considering the environment that individual is in. And so some of the advocacy programs that employers have implemented have been intentional about getting better to know what's happening with that individual and their family, and then helping them solve their issues around that. So I think when we think about this broader well-being strategy, I think it's more holistic, and frankly, I think it's a common denominator in the advanced primary care models that we talk about, and frankly, in the more sophisticated, more specialized care models, where if all we're doing is treating the thing in front of us, we're missing these other factors that influence how the patient reacts, or how the employee reacts, or their family reacts, and how they move forward. So the danger in being too siloed in our thinking is we will miss that this is actually the opportunity to think more holistically around the individual.
So, we heard earlier from the first panel about making the right choices easier for both patients and providers. And, over the past few years, we've seen incredible advances in digital capabilities. So I'm wondering if you could share some experiences or examples where we're using some of the advances in technology to meet people where they are and helping them make better choices around promoting their own heart health. So anybody want to jump?
Well, we have at the ACC a very active innovations program. We actually have one of our senior cardiologists, John Rumsfeld, who's a cardiologist in Denver. He's our chief innovations officer, and his job, I call him kind of the Lewis and Clark at the ACC. He's exploring the frontier of what's new in digital health. And we have entered into partnerships with quite a few companies. I think we're up to 8 different companies in the digital health space that we're working with, one of whom is a platform player that ties together remote monitoring into a common portal that then feeds back into your EHR. Think about EHRs in the U.S. right now. They were designed primarily with the hospital in mind, maybe with the group practice in mind, but certainly not population health management in mind. And a couple of those companies are giants. I won't mention them here, but they're giants. And they make a lot of money selling and supporting EHRs for health systems. But those are very poor proxies for workflow management for the type of management we're talking about right now. Matter of fact, most cardiologists would tell you that the EHR most of the time gets in the way of good management, and what it outputs in terms of documentation is gobbledygook for anybody else trying to read it. But these other players that we're talking to, they are creating portals for this very reason. Most patients with heart disease are not in a hospital at any one point in time, or not in a cardiologist's office at any one point in time. The vast majority of their 20, 30 years they're going to spend with this disease, they're out working, traveling, at home, wherever it is, but they're not in the hospital. our ability to connect and monitor and document that and measure that and then take intervention, take some action based upon physiologic information or other information is key. So we believe that the future lies, most of what we're talking about in terms of avoidable costs in cardiovascular disease, the avoidable costs occur inside of a hospital. I think somebody at the first panel says one person's cost is another person's income. We're just going to have to accept that as we try to redirect resources to get more value for populations, hospitals are not going to have as many patients in them. That's what we should strive for. We should try to get patients out of the hospital, have the length of stay be either shorter or longer to get the best outcome, but not have as many admissions. So on this remote monitoring, our ability to connect with patients, I think this is the true frontier in medicine. Unfortunately, reimbursement, again, we're back to Star Trek medicine, Flintstone reimbursement. The reimbursement doesn't always support that. So we're going to have to work with employers, CMS, and others to accept if we really want the best value for patient management, we need to leverage all these technologies and make sure there's a compensation model. It may not be a CPT code. And that's one of the problems we have in this country right now, worldwide actually, is we are fixated on CPT codes, ICD-10, APCs, HOPD, DRG. We're fixated. That's how we get paid. The employers and CMS and others, we're going to have to develop a whole new way of coding for population health management, something that can be standardized, evidence-based, scientifically supported as a new measure. Because if every payer represented in this room is going to develop their own unique platform for how they're going to reimburse for episodes of care, for population health, we're going to go from Flintstones to something below Flintstones. I don't know what that is, very quickly. So we need to have agreement among the payer community. Let's work together to define and standardize the new payment models.
Mike or Chris, you want to?
I was going to, first of all, I agree 100% with your comment there. It was one of the principles that we have established on episodes is it makes no sense for every one of the payers to do their own thing here. I mean, how can anybody react to different sets of incentives? And when you actually are in meetings that I've been in, and of course you've been in a lot more than I have, with provider organizations, they essentially look at what each of the payers is incentive, which clearly are not on the same page, and they find the two things that seem to be in common among the 10 payers they have. Okay, we'll focus on those two things, because the other things are so dissipated that they make no difference, right? So we think we're innovating, but we're just confusing. And I think we have to get on the same page. So I totally support that. Where I was going to go with that, though, was the issue of making the right thing or the right thing the easy thing to do. And a lot of this is an area I think employers actually have helped to move the dime. I mean, they have improved their cafeterias, improved their vending machines, improved their meetings in terms of how they're doing, encourage more activity and all of that. But it's also a great opportunity, I think, when we think about public-private, because that's only when people are at work and they go outside. And, of course, they still maintain choices even at that. So, I always think about what I think is the greatest success in public health so far has been in smoking, where we brought the population from 60% of the population smoking to 16 of an addictive habit. And it happened not because of one thing. It happened because of a lot of things. On a better day, I could name 20 things that happened that made that happen. And I think all these things we're talking about, I think we have to be ambitious to have all of the above if we're going to move it.
Chris?
Yeah, so two things that come to mind. I think that the work happening around telemedicine and telehealth, and I think in my previous role in the Division for Heart Disease and Stroke Prevention, we did a lot of work with the community guide looking at evidence around digital interventions and mHealth. And so I think that's one area that we've seen a lot of positive effectiveness around improving medication adherence and other things related to cardiovascular care, and using technology, making it more easy and accessible for folks to get reminders and access educational information. And the other example that I've learned about recently is the National Diabetes Prevention Program, the Operations Center, where they have a center set up where there's a lot of online resources. There's the peer-to-peer sharing from trainers and about techniques using for administering the lifestyle management program, and then accessing data related to that. And so I think that is a pretty innovative way to make those resources available broadly to folks who are delivering the system and as well as monitoring the progress that's being made through those where the interventions are being delivered.
Great. So, Chris and Mike, I'm just wondering if either of you could share an example where you've got significant employer alignment with the governmental agencies in driving to achieve results around the 618 initiative. Because I think that my experience in Rhode Island was that all the public entities were there, the NGOs were there, the business community was sort of not quite toeing the water, but they weren't all in yet. So I'm wondering if either of you might have some examples where that's really playing out and what you can attribute that to.
Well, I'll give two examples. Some of our coalitions have really adopted the National Diabetes Prevention Program, promoted it with the employers, and of course there are many private service providers that have been qualified as a national DPP provider, and they've helped to promote them in their communities, and employers are in fact using them. So I think what I hear from those coalition leaders is that they really like is this is an evidence-based program that very few of the things we've been doing is as evidence-based as the national DPP. So I think that's very encouraging. The other example that and I'm thinking of Houston, Philadelphia as at least two that have done that, and I think we probably have opportunity to do that more. The other example is one of the coalitions that helped to drive closing gaps in care around hypertension control, blood pressure control with lipid management or whatever, right? And Minnesota did that, and they are one of the case studies that helped to close the gap in gaps of care around that in that community. And I don't remember the exact percentages, but there's a big gap between what's average and what's best practice, and they brought it to best practice in their community. And it was led by the employers in that community. So those are two examples.
And Mike works closely with our subject matter expert around the employer engagement, so he knows that area. But I also could speak a little bit to we've spent a lot of time this last year working with OPM, the Office of Personnel Management, and working to get on their cycle of making sure that services or preventive services are covered, like around making smoking cessation treatment services more readily available, and then doing some performance management around smoking cessation and hypertension control for the plans that are working with the Federal Employee Health Benefits Program. And we have seen good success there and had a lot of progress and gotten some of those measures put in. I know the Million Hearts team has been working in that area too and had a lot of good success. So I think we've been referring to the FEHB as kind of a model in terms of what other state government organizations could consider.
I was trying to think of an example in the other sphere, which is smoking. And of course, as I said before, I think we've had a lot of success. But one of the things we were educated by the CDC in the smoking arena is that we're doing a lot of work in the mental health arena. And it turns out that one of the pockets of the population that still has a very high smoking rate are those people with a mental illness. And of course, this is a classic example where we treat the issue in front of us but don't look at the person more holistically and try to support them more holistically. And it turns out that smoking is not good for their mental illness. Who knew that, right? Well, the CDC educated us on that. We've tried to educate on that. But I think as we tackle mental illness as an issue, I think we should think about that being part of the CDC's effort to control smoking as well.
Great. So before we open it up to questions from the audience, Chris, a wish list in terms of what you could have that would drive the agenda forward for the 618 initiative, what would be at the top of that list?
Oh gosh, I think that right now we are, as we're going into the years 4 and 5 of 618. I think we are interested in learning if there are other interventions or other areas that we could potentially make make headway in and continue to advance reimbursement. So I think we're doing some exploration around that, open to feedback and input. So it'd be nice to expand that list and look for some of those places that maybe we have the window to work with employers and with providers, and that we can bring those worlds together. I think that that's not a specific topic, but I do think we would like to continue to expand the work.
Great. Tim, besides the right reimbursement model to get past the Flintstones, what else is at the top of your wish list?
Well, I think the ACC can continue to play a role in terms of guidelines and scientific statements, what we call solution sets, whether they're expert consensus documents. But I think we need to continue to educate our members and the teams that they influence and the teams that they manage and the organizations they work within around best practice and the guidelines, and to embed those into workflow and to make that workflow more uniform and reduce the variation within the teams and the other cardiologists within those groups.
Mike?
Well, I would say we tackle a lot of different things, and and a lot of it is really based on what's got our attention at the time, right? And so it's really difficult to imagine that we can attack everything. And so the issue is, if these are the priorities, how do we make those priorities and actually execute against those priorities? I think we haven't been at the table as much as we could be, and I think we are a huge asset in this opportunity, and I'd love to collaborate to make it work. So
Great. Well, thanks. Let me turn to the audience and see what questions folks have.
Hi, I'm not sure if this is a question, so I'm just going to go with it, and you can take it as you will. I am very familiar with 618, and it's a wonderful just initiative to just put things out in front of people in a really concise way with a lot of evidence to back it up. But one of the things, if you look at the interventions, is medication management. And so I guess I would ask the question, and I think earlier the comment was made of, I guess I just take this pill, and that's now my life. So in knowing that medication is, for some, one of the things they're going to have to deal with, can you speak a little bit more to what some of the benefit packages might look like with incorporation of 618, or how is medication management and even the pharmacist role playing out in a lot of the different work you're doing?
From a payer perspective, clearly designing the benefit package to give people the easiest path to the best choices with insurance value-based benefit design is key. And so the ACA brought a lot of that forward, but many plans are going well past that in terms of making sure that the agents that are doing the best job of managing the risk factors have the lowest co-payments. And so that's something that's been important to us, and I think many other plans that offer insured products. But Mike, from an employer perspective?
I'd like to say we got this under control. So far, I haven't said that very often, right? So, if anything, as you know, the cost sharing has gone up dramatically. I mean, we're over $1,000 in our deductibles typically, and that's been exacerbated by the HSA tax regulation around HSAs, which has made it hard. Now, it could be that these medications could be exempted from the deductible, but frankly, most employers have not done so. And so we try to educate on value-based design, but I can't say that it's moved as much as you'd like it to think it has, But I think it's a serious issue that plan design does matter in terms of adherence to medication, and we do know, certainly for hypertension control, it is about medication as much as anything else. So I'm supportive of what you're saying. I would say, though, these issues are not unique to this disease category. These issues are broad, and we talk about them in that context, in that broad way. But I think continuing to reinforce it, I think, is a smart move. So, yeah.
I'll just add real quick that I think that we talk a lot about in heart disease around the role of engaging the pharmacist. And you may have seen the recent community guide or Community Preventive Services Task Force finding showing that there was strong evidence for pharmacy pharmacist-based tailored interventions to address and improve medication adherence. So I think there's opportunity to continue to look for ways to engage the pharmacist. And I mean, it doesn't answer your reimbursement question because that is part of the challenge, we know, but is an area that we're seeing a lot of evidence that involving those other team members in this process to help people maintain medication education as well as sticking to the regimen. So.
Sticking with the reimbursement theme for a minute, I have two questions. One, I was interested, Tim, to hear about the experience in Tennessee and Virginia with the community paramedicine. I coming from the rural West, I certainly appreciate the ability for them to offer something in rural areas, but my experience is that there are many urban areas where they have a lot to offer too, and a big stumbling block has been reimbursement or the lack thereof, where the EMS just cannot be paid, for example, for things other than transport to a healthcare facility. So the question for you is, did you have some sort of waiver? Were you able to reimburse? And then for Michael, I was interested to hear, since the relaxation, well, it's not really relaxation, but the rule change around HSAs now being able to pay for chronic disease meds like hypertension meds before a deductible, whether that word has gotten out, and are you seeing a change in employers making that choice?
Yes, so we actually, as the hospital, paid for the community paramedic visit. So we did a computation. This is something that all hospitals have to do, at least they should do, because a full hospital doesn't necessarily mean a profitable hospital. So sometimes it's actually not good to have every patient as an inpatient inside the hospital. You may not make a contribution margin, or you may make less contribution margin from that patient than you would from another patient because you're using capacity. So we made a calculation that there are a certain number of patients that it's worth our investing in the community paramedic to visit as a way to reduce that avoidable readmission event. What that also does then is open up capacity for patients that otherwise we may be turning away from the hospital because we were full. So we just decided that we would redeploy some of those existing assets. You could take this on a large scale. Just one other example. If you've not heard of the company Medically Home out of Boston, go look them up. They're a very interesting company. The guy who started this company, a very interesting guy, Medically Home, not Medical Home, but Medically Home. And the premise of Medically Home is patients should be at home for their inpatient care. Now, not every patient qualifies because there are certain inclusion-exclusion criteria, but this company has proven that patients actually do better, certain types of patients do better when they're not inside the hospital. They either get them out of the hospital or get them out of the emergency room and not admit them so that they are at home. And so what the Medically Home has done is 30 days of home-based inpatient care is cheaper than 4 days of inpatient care at a hospital. And they essentially bring everything to the home. Now, I know it's radical. We had the guy who founded this company speak at a conference last week, and the oxygen practically left the room whenever he was talking because everybody's thinking, oh, no, we're going to lose all of our admissions. But when you put that aside and you actually look at avoidable costs, which I think that's something we should all focus on. We're spending more per capita in the U.S. than anybody else, but not always getting better results. So it's not a resource issue. It's how we use the resources. And in this case, can we use those resources to have somebody at home where their likelihood of getting MRSA is zero, because you can't get MRSA at home, you can get MRSA in the hospital, but get them out of the hospital, have them spend that time in their home. Well, that's radical. There's no reimbursement for that right now, so the people who are using Medically Home are paying for it like I did the community paramedic. So these are novel ideas, but somewhere in this exploration and a dialogue around these novel ideas, I think we find a new care model. A new care model and a new reimbursement model go hand in hand.
And to address the question, I think the answer is it's all across the board, right? So there are clearly enlightened employers that have started to pay for chronic disease medications, sometimes generic only, because, again, they're concerned about the cost factors around drugs. I don't think they typically think about it, again, on a very siloed basis. They wouldn't just do it for one disease. They'd think more broadly about how they would do it. And yet there are, even before the liberalization, there was some point of view that you could do that before, and there still was not adoption by the employers. There's kind of this resistance, and a lot of it is, frankly, a little bit of a frustration on the drug side in terms of drug prices and things like that, where they're kind of opening it up. So I think frankly, if we were working together, we would have targets of what percentage of so and so did that with that thing, and then we would work towards it, and we would measure it, and we would, that would be a plan. I think we are educating but not executing, if that makes sense.
I think we have time for one more question.
So, Stan Shandling from the Minnesota Department of Health. Over the course of 3 panels, I've got like 12 different things I could talk to you about, but I'm going to mention one and then a question on one. This whole idea of best practice and evidence-based, I think the problem is that time passes us by very, very quickly in the technological world. So, for instance, I have said to a lot of my colleagues that, what about better practice? And I'll bet you that as we're just sitting here talking about evidence-based, DPP, for instance, I could bet you that on all the poster sessions that you would see at a major conference, there's probably a better one. And how is it that we're embracing that? Which gets into David's point that he made earlier. How do we get to logic, to implement some of these great ideas? But perhaps the most aggravating to me is this. It's the idea of sustainability. So, for instance, we get CDC grants all the time, and we're on these 5-year cycles, but there's never been a grant application where we had to address how it is that we would take a really good thing that we were able to accomplish and sustain it. We're never told that that's an obligation under that grant to take something that's really good and sustain it. So when that grant cycle is over, done, goes away. It's in la-la land somewhere. So my question to the panel is, how is it that we sustain really good things if we find them, like your paramedic thing? How is it that we sustain it, get it macro and involved across the United States?
Some of that gets back to making it easy, and I want to refer back to the Green Bay example, because what seems to have happened in Green Bay is there were some relatively easy practices in terms of getting people more physically active and making better choices. It's gotten hardwired into how the city operates now. So there's a sustainable model that I would encourage people to go back and take a look at. But I think it gets back to a couple of key things: reimbursement, alignment, and making it the easy choice.
I was just going to add, because part of the way we think about other issues, not necessarily these issues, is that while we may have a recipe that seems to be the best practice in one location versus another, we talk about the need to localize, to actually adapt it, understand it, engage stakeholders in that community to help shape it so that they own it, right? So if you start with too much of a cookbook, it's somebody else's. If it's something they help to co-develop, it's theirs. And frankly, it gets retooled a little bit to consider those unique circumstances, geography by geography. And so when we think about the National Alliance, we think about lead, leverage, localize. But the localize is very important because what is going to work in Wyoming isn't going to necessarily work in New York City or vice versa. And we need to understand those unique differences, and we have people on the ground that know some of those unique cultural, stakeholder, there's all sorts of differences in these various areas.
So I think that one of the hopes around 618, because the work that's being done is really being done that's funded by the division. So the work that you're talking about, Stan. And then the hope with the 618 initiative is that it's going to help build some sustainable partnerships that help address reimbursement and coverage, and then hopefully enhance and accelerate the work that the divisions are supporting and funding, and in turn, hopefully make that more sustainable within the communities, because the grants may change the next cycle. So I do think, though, that, I mean, for what we're seeing and from, my time at CDC, the partnerships, and I think we talked earlier about the leveraging the resources you have in the team, that seems to be an opportunity. I don't know if that's addressing it directly, but I think that is one of the things that we've started to see in the states that have worked early on in 618 and then rotated off and now are quote unquote graduates and working back with new states. Is the way they've been able to sustain that work is through the partnerships that they built and then the changes they made either with their MCOs or others. So, I think that we are optimistic and hopeful that providing some of that implementation support around policies and reimbursement can help continue to make that more sustainable and have longer term effects.
Great. Well, thank you all for your questions, and please.
Let's squeeze in one more
question.
One more question
Sure.
over in the corner.
Yeah, my question is for Dr. Attebery. You mentioned the shortage of cardiovascular specialists. What's the college doing to address this issue, especially given the burden of heart disease we face?
Yes, there's actually two issues there. Cassandra is the Executive Director, CEO of the Association of Black Cardiologists. We work very closely because there are two issues really at play that we have to address. One is the shortage, and one is the composition and the lack of representation by females and underrepresented groups in cardiology. Cardiology actually is one of the worst when it comes to diversity and inclusion. Embarrassed to say that we are working on that aggressively with ABC and others, but that actually brings up good health, because we know there's an association between those who serve patients and the outcomes that then you can generate with that service. So we owe it to the patients we serve to make sure we are bringing in the pipeline. The new cardiologist of the future needs to look like the patients they serve. There are too few cardiology fellowship programs in the country to meet all the needs. We only graduate 850 cardiologists in the year in the U.S. HCA, one health system. It's a big health system, but it's one health system. They're recruiting 300 cardiologists for 2020. Now, there's 850 graduating, and 300 of them HCA wants to hire. I don't have to be that smart. I think we have a shortage of cardiologists in that kind of environment. So we need to start and expand existing cardiology fellowship programs with GME, DME, IME support and financial support, federal government support, and then under the ACA, if you have a hospital that's not a teaching hospital and you want to start a cardiology program, you can do that. And HCA actually itself as a health system is going to start some new cardiology fellowship programs. Last point I'd make, let's not forget about the advanced practice providers. When used properly, they can generate effective capacity to make up for that shortage of cardiologists.
Great. Well, thank you. And please join me in thanking Chris and Tim and Mike for their insights and experience.